Yeah, I did it. Awesome. Thanks. So good morning, everyone. My name is Mike Wilkinson, and Heather Sinclair and I will be moderating the day. So if there's any problems or questions, just come to us. Um, we had the last ECT Education Day in 2013, and that was targeted for a wider audience and all the psychiatrists basically in Fraser Health. But this year we were asked to do another Education Day, but we narrowed the focus to ECT practitioners and clinicians, the people that actually do the delivery of these treatment. So, and we created the program around a lot of feedback about what people were interested in and what they wanted to be updated on. So I hope today is beneficial for us all. A few housekeeping issues. First and foremost, I would like to thank Daniela Derrick. She can't be here today. I think she's on vacation, lucky her. And she helped pull together a lot of the organization and booking this beautiful lecture theater that just opened. I want to thank Heather as well. She did a lot of the shopping, as well as the organization, Amanda and Christo, and as well as Nigel for supporting this. And all of our being here as clinicians. The washrooms just outside the lobby. Food, we're supposed to not bring food in, but if we do, just sort of keep clean up after ourselves is what we're asked to do, of course. And then the sign-in, don't forget, is at the front desk, but we'll also have a sign-in in the afternoon as well. I think some people are coming in for only half days. And finally, the certificates for your continuing medical education can be picked up at the end of the day or on your way out at the desk. I think we are a small enough group that it would be nice to get to know each other, which is one of my agendas because it's so hard to know people face to face. So I'm going to ask everyone to actually just sort of raise their hand or stand up if you're so bold and introduce yourself and say where you work, and then that'll be great. We also have the pleasure of having some medical students join us. They're from Burnaby, and due to our commitment for education as well. So if we can take a few minutes, should we start from the back row? Heritage. Good, you can make it. Dr. Ocean. It's a lot of Chilliwack. Lindsay.
Also at Maple Ridge Hospital.
I'm Heather Sinclair, ECT coordinator based out of research.
Mike Chavez, I'm in Richmond. Nutrient data
Nigel Fisher, the program director.
Great. So I will turn over for opening remarks from our distinguished.
Thanks, Mike.
Dr. Fisher.
So, I won't keep you very long because it's a really packed program that you've got. But I wanted to, Mike thanked all the folks who've organised today. I wanted to thank Mike, who's, for the first time, we've got a region-wide ECT lead. I think you've been in post for about 6 months, is it now? Yeah, and has made a real sort of difference in trying to work with our site ECT coordinators to try and get some consistent standards across the patch, and this day is a part of that. I'd also want to thank our speakers. As Mike alluded to, we had an event like this 2 or 3 years ago, so I've heard some of the speakers before, and they're all very, very good. I think we're fortunate not just to have sort of local experts here, but also some national and international experts. And the other thing is, I think, just to sort of touch on ECT, which I think has a peculiar place in the range of psychiatric treatments that we offer, and that I think it's really effectively the only procedure that we do. Everything else is either prescribing or talking based. And I think there's something sort of unique about ECT, and it's particularly important for us all, both those who are actually giving ECT treatments, but also those who are prescribing ECT, to be fully up to date with the research and clinical practice, and to really understand what's involved in providing ECT in the best possible way. And I think, I guess that relates to the work that's going on provincially around having a privileging and credentialing system for physicians giving ECT, where there will be expectations around training and experience of giving ECT. The last point I wanted to touch on is a bit more specific to Fraser Health, and that is just reinforcing the point that ECT is a regional service that we offer, and that whilst whenever we can, we try and provide ECT as close to the patient's home as we can, sometimes that's just not always possible, and at times we have to move a patient from one site to another, and it's very important that physicians are able to collaborate around that, so that we don't have a turf war between physicians as to who does what, and we can't give your patient ECT because they come from the other side of the patch. So we need to sort of fully understand the issues that are involved in that. So that's all I have to say. So welcome again, and particularly those who've travelled quite a long way, actually, coming in from Chilliwack and Abbotsford and so on. So I really appreciate you giving up the time. And I think, are we handing straight over to Dr. Chan, Mike, or do you need to? Yeah. So thank you.
Okay, so our first speaker is Dr. Peter Chan, who'll speak on contemporary ECT, translating research into clinical practice standards. Dr. Chan is a geriatric and consultation liaison psychiatrist who is a fully qualified subspecialist in geriatric psychiatry and has practiced since 1996 at Vancouver General Hospital. He is recognized nationally for involvement in the updating of the CPA position paper on ECT, published in 2010. The publications from 2007 to 2008 Canadian ECT survey, that's the CONNEX, and teaching an annual update course on ECT for practitioners at the CPA. He is a lecturer for the Canadian Academy of Geriatric Psychiatry's review course and the past president of the Canadian Academy of Psychosomatic Medicine for consultation liaison psychiatry. He is the medical manager for the ECT and RTMS programs at VGH and UBC hospitals, and an ECT TMS researcher and practitioner. Please welcome Dr. Chan.
Thanks very much. Can you hear me on the mic? Yeah, okay. Thanks very much, Mike and Nigel and others for having me here today. It's a real pleasure to speak. I think I might have said this before, and you might have heard this before, that for me, being in Fraser is kind of like salmon swimming back to spawn kind of thing, because I have a real affection for the Fraser group, and I had at one point been part of the Royal Columbian Hospital ECT service, as well as the New West Surgical Clinic, which I think you probably heard about, or some of you have heard about, which is associated with the Royal Columbian. So there's, we I think at that time established a private-public partnership, which I think it was unique in Canada at that time, and just lots of warm memories of that. So currently, I'm at Vancouver General, and so as Mike said, I'm the head of the ECT program, the medical manager for ECT and TMS programs at UBC and VGH hospitals. And we have a very busy volume of practice at those sites. Between the two, we do up to 45 patients per week. But despite that, we have capacity challenges, which I'm sure you do as well. We'll talk a little bit more about that. I'm going to talk today about the physiology of ECT and some of the biological mechanisms that are theorized to be why ECT might work. Also going to talk about indications, maybe primary indications and secondary indications. And I'm also going to talk a little bit about the practice guidelines and policies that we may have locally, provincially, and nationally. Now, I understand that locally there isn't a specific policy and procedure pertaining to ECT practice. There probably is one for nursing, but we don't have one in the Fraser, I believe, at this point in time. But if it helps you, we don't actually have one at Vancouver General UBC either. What we did at the time when the BC ECT guidelines were developed in 2002, we adopted it as our standard, as our policy and procedure. So it's not the best doing that. I think it's better still to develop policies and procedures and not just to adopt, especially now that the BC ECT guidelines are quite old now. 2002 doesn't really talk about bifrontal ECT, for instance. It's good to have your own policies and procedures guiding ECT practice if you can develop it. So disclosure, none. Stigma. I'm going to talk about stigma just to start off with, because some of you may have seen or heard about the Toronto Star series. 2012, it was published as sort of like a supplement of the newspaper. And in the end, even though it was supposed to be an expose of the state of practice in Canadian ECT, it really became, I think, more stigmatizing of the treatment than not. And there was a number of rebuttals about this, like from the Toronto group at the CAMH and such. But I think that the media perceptions are probably maybe better than 10 or 15 years ago about ECT, but the stigma and the negative bias that one can see about ECT is definitely out there. And not just out there in the lay public, but even amongst our profession. So some of you may know that the FDA still hasn't come to a final decision about this, but in the States, the FDA has been reviewing ECT in terms of putting it, what class of device it is, amongst all the electrical devices and all the just devices in general that are for medical use. And they are at the point of looking at whether they're going to classify it in this class 3, which would then, if they were to be classified as class 3, then the manufacturers have to submit safety data, which would mean new studies, especially around cognitive impairment, which would make it really, really difficult to do ECT if the FDA actually came out and decided upon that. As far as I know, it's sort of stuck right now. And hence, there's an article by one of the staffers, I think, at CMAJ talking about this. But interestingly, the photo that accompanied it, I mean, it was more stigmatizing, I think in itself, right? I mean, it showed somebody that's so fearful, receiving ECT. And the president of the CPA at the time wrote a letter around this. So I think the point to be made is that, we have stigma that I think the lay public has a certain perceptions of things, but we also have to be wary that even within our profession, our healthcare profession, that there can be these problems with stigma around ECT. So, one of the studies looking at this, not specifically about stigma, but specifically about what are the barriers in terms of access, and divided up into several types of barriers. So resource barrier was one. And any of you who's run an ECT program will know that anesthesiologists is going to be one of the biggest barriers. So this study came from the Canadian ECT survey, 2007-2008. It was distributed widely, identified about 160-ish, 161 ECT sites across the country. And we had a 61 to 71% response rate, depending on which section of the survey. So it was a fairly good response rate. And what this shows is that for anesthesiologists, it was over 50% of the sites that responded identified having anesthesiologists as being a barrier in the sense that you can't get enough anesthesia time, right? But there are others as well. It's hard, kind of fine print there. It may show up better on your handout, but you can also have limitations in terms of nursing, especially in helping with the ECT, or with just psychiatrists doing it. Space barrier was another one that was identified, particularly the ECT treatment room and the post-ECT recovery area, and also logistical barriers. So any of you who've done ECT will, for those who are outpatients, will have seen that one of the barriers is that requirement of having the person who received ECT be signed out to a responsible adult and to have them supervised for up to 24 hours. I know that some institutions are much more rigid around 24 hours and some not, but really the Canadian anesthesiologist guidelines are very clear. It should be 24 hours after a procedure with a general anesthetic like ECT, particularly since they had a seizure as the therapeutic effect. But still, I mean, I think that it's not just any short-term procedure like, say, a DNC or something like that. This is something that relates to the brain, and there's a seizure associated with it. So there are some other logistical barriers that are identified as well. What are the guidelines and policies? Well, and why do we have it? Probably if we didn't have it, we may be still doing this. This came from a article in Doctor's Review, that stellar journal that I sometimes read, and then especially the back pages. So Doctor's Review talked about this turn-of-the-century physician who piloted using this electrical device to, I guess, make people smile, from what it sounds like here. And other physicians kind of did that, but of course had no evidence. So, I think we should have guidelines and policies. We shouldn't really be doing this kind of ECT. So what are the guidelines and position papers out there? There's the APA task force. It's supposed to be reviewed. Apparently, it's kind of stuck in the mud there, but it's getting long in the tooth. It came out in 2001. There's the Royal College Handbook, which is pretty useful and quite user-friendly. It just came out in 2013, the latest revision of that. There's our BC ECT guidelines. Talk about that a little bit more. And then the position paper, just to be clear, the CPA position paper is a quick synopsis of the scope of clinical practice, but is not a CPG. It's not a clinical practice guideline. So we don't, at this time, have a Canadian set of national guidelines for ECT, unlike other countries. So just a quick run through with the APA guidelines, for instance, which I think guided us in the development of the BC guidelines. So a lot of what you see in the BC guidelines will have reflected what was said at the time in the APA guidelines. There's been changes over the years, and I'm not going to go into this in detail because other speakers are going to talk more about that. But I think what's clear is, for instance, sine wave device is not justified, and that's back in 2001. There should be kind of a therapeutic window that you should be looking at when you're doing ECT, and this therapeutic window where if you're below that, you may have less efficacy, and above that, you may have more cognitive impairment. And then it goes back and forth whether ECT causes lingering cognitive impairment or not, and I think other speakers will talk more about that. That's the APA guideline. When we did our survey, and this is published, we found that you can see that for the APA guidelines, the majority of the sites used this as their main guideline if they were adhering to something. A small handful were looking at the Royal College Psychiatrist Guidelines, which at the time I think was 2005. And then some people, the BCers, I would hope, followed the ECT guidelines in our province. What kind of information would you consider giving with somebody who's about to receive ECT, or at least who you're proposing ECT for? Well, there's going to be information that I think Dr. Doyley in her part of the talk is going to talk more specifically about consent and what kind of specific information. But I think that nowadays you really should be the one that is going to, at some point, as physicians, talk with the patient. It really shouldn't be delegated to interdisciplinary staff. I mean, they can help out with the process, but I think as physicians responsible, whether it's attending or who are ECT practitioners, I think really it should be you that's going to, in the end, talk to the patient about ECT and to be able to answer questions. It's helpful to have a brochure and a video. So I'll talk about the video more. But is there a brochure, Fraser? Is there one, an ECT brochure? I thought there was one, but is there? Right. So the comment is that, yeah, there was an old one, but there has to be some revisions. The BC ECT guidelines actually has a brochure, but it's unfortunately kind of embedded in the middle. It's like from page 51 to 63. So if you're kind of running around and you can't find a brochure, you can always Google BC ECT guidelines, get to page 51 to 63, print it off, and give it to the person. It's a very simplistic brochure. It was meant for the lay public, of course. So the video. So you can get it through this website. This is the more specific domain. And this is the organization connects the Canadian ECT survey group that I'm part of. Dr. Gosselin, who will be here later today, is part of, and a national group of ECT practitioners. By the way, we're going on to our second phase now, where we're trying to look at writing accreditation standards for ECT nationally. So this is what that web page would look like if you get to the, when you click the patient families, you're going to get here, and you can see that there's 4 versions: English, French, Punjabi, and Cantonese. And we've got this guy, I think a lot of you know him, Ray Lam. He narrates the video. It's 20 minutes long. It's done in a very clear way, and it was an accompaniment to the BC ECT guidelines. It was developed in around 2003, 2004. But it's still very contemporary. And I think the thing that distinguishes it most is that there is a real live treatment that's filmed with the patient's consent, of course. It was one of our patients who at the time was on maintenance ECT for like 10 years. And she said, yeah, I'll do it. And she's actually also depicted in the video as giving an interview about the experience of ECT. So, I think that these days there really isn't an excuse to not show the video, because you can access this. You can get the family to look at it at home. This is free. You don't need any passwords or anything. You just go in and show it. Way easier than the DVD, which had been produced at the time, but I think they're all pretty much lost now. Whether it's lost or just there's no DVD players anymore, I think is the other concern. But you can see some of the websites that I talked about, these guidelines, the BCCT1, CPA. The Mayo Clinic has a nice website for patient information, just in case people wanted an alternative view from the Mayo. I think it's well done. It's not a video, but it's like patient information. And then, I mentioned about the accreditation standards and how we are hopefully going to model what they've done in the UK. And Scotland did a separate process to this as well. And this is all published on the internet, what they do and some of the quality indicators they've looked at in terms of the various sites that they've audited. There's similar services like that in parts of Australia. So looking at an ECT consultation, you're going to get a lot of information today. And I hope that at the end of the day, for those who are going to become ECT consultants, that you kind of keep this in mind, that, do you have an indication for the ECT? And you can divide that up into primary or secondary. Is there a contraindication or risk? So Dr. Schabtz is going to be talking a lot more about the medical risks of ECT. But what I mean by psychiatric risk is what I mean.
Nephrology, pod 3, room 23, code blue, critical care tower, 7-4. Nephrology, pod 3, room 23, code blue, critical care tower, 7-4. Nephrology, pod 3, room 23.
What I mean by psychiatric risk would be this undiagnosed bipolar illness, right? I mean, who goes on to have ECT? People who are treatment refractory, people with psychotic depression. Some of those people have actually a bipolar disorder that could be unmasked by ECT, so you have to watch out. Concurrent medication, just think, what are you going to discontinue? What are you going to hold, say the night before and the morning of, and which one are you going to taper prior to the course or during the course of ECT? Consent, considering whether they're involuntary or voluntary, and irrespective of that, figuring out whether they're capable or incapable. You know, at my institution, VGH, I mean, pretty much anybody comes to emerge gets double pinked, and automatically the Form 5 gets signed off as that they're incapable of consenting to their medications, pharmacotherapy. Like is that good? I don't know, but I know that that's what happens. But don't assume that they are, just because they're incapable of directing their pharmacotherapy treatments, that they're also incapable of directing something like ECT. So I think you can have somebody who's incapable of consenting to medications, but capable of deciding on ECT. And that's why the consent process is so important when it comes specifically to a specific healthcare procedure such as ECT. Outpatient considerations in your consultations for those who are getting outpatient ECT, you know, and they follow behavioral restrictions, fasting and not driving within 24 hours. And then talked about this a little bit earlier, like how you might arrange transport and, you know, who's going to pick them up, and that can become a barrier with some people. Generally, I quote response rates as being 75 to 85%. In the literature, there's support for the elderly folks with depression will respond better at 80 to 90%. Now, we're talking about depression here, okay? And then in those with treatment resistance, and that can be variably defined, as you know, but with treatment-resistant depression, it may be as low as 60 to 70%. I think, you know, at VGH, I don't think we're as low as 60 to 70%, even those who've trialed a million types of antidepressants and augmenters and whatnot. You know, I think we are probably closer to the 80 to 90% mark in terms of ECT response. So there are some supports for those statements. You know, one of the big studies at the time back in 2000, between 2000 and 2004, is this the CORE group, which is a large group of researchers in southern United States, and they published a series of studies, still publishing series of studies. They're an excellent group to, you know, get evidence for in terms of what might guide our practice. They found in their cohort, and they used bitemporal ECT, you know, that they had an 80% overall response rate. Treatment-resistant depression was not a predictor of response, but psychotic depression was. And that comes up to the point that, you know, if you've got somebody who's psychotically depressed, you certainly should think about ECT much sooner rather than looking at a combination of antidepressants and antipsychotics, because they will generally respond better than those combination of medications. And ECT, you know, with ECT, you could probably get a quicker remission. There's some support, as you can see, that with age, you get a better remission rate. And then something about response, like people ask, you know, often, whether it's healthcare providers or patient's family, like how fast is it and what's the average length? Well, the average length these days is probably about 8 to 10 treatments. But how fast do you think that there could be a response? In their study, the median time to the response was 3 ECTs. And then they also published on the relief of suicidal ideas for those suicidally depressed. And it was within 4 ECTs. And you can see when you graph their data that at around, this is first response, first time when they respond, sustained response. And you know the response is defined as 50% reduction in a standard scale like the Hamilton Depression Rating Scale. and then remission, which has a specific definition as well, as a lot of you know. So you can see that by about 3 to 4 treatments, you're getting into quite a number of people responding. But when you look at remission, you have to kind of keep on going a bit longer here. Okay. So, I think one of the take-home points is that you should really say to patients' families that it might not be that after 1 or 2 or even 3 treatments that you're going to see a response, because sometimes people have this expectation that they're going to have a quick response to 1 treatment or 2 treatments, and they become kind of demoralized, or they might even withdraw consent because they think, well, this isn't working. But this is something to watch for. If they respond really, really quickly, even within like 1 or 2 treatments, then you have to start thinking, is there like a bipolar diathesis? Because maybe they're switching over to hypomania or mania. So if it's that quick of a response where they have a tremendous response by like 1 or 2 treatments, then you have to be something to keep in mind. Primary indications. So as I mentioned, one of the things you do with your consultation is establish an indication. And their primary and secondary, go into each of them in turn. So major depressive episode, mania, mixed state, schizophrenia, schizoaffective disorder. In regards to mood disorders, whether we're talking about bipolar or unipolar depression, if they have features that you can see here, a particularly psychotic episode, psychotic mood episode, or a mood episode with a lot of suicidality or rapidly deteriorating state, physical state, then think about ECT sooner than later. Also, if the patient prefers it, that is okay to recommend ECT, and you think that it's safe for them to proceed. And a history of good response will, of course, predict future response. And then this thing about catatonia I'm going to talk about, but certainly people catatonic can respond very, very well and very quickly to ECT. What about unipolar versus bipolar depression? It appears in several reviews on this, from reviews of RCTs, that it's equally effective in both conditions. However, it's likely that those with bipolar depression would respond quicker, and this is based on some studies, both retrospective and prospective, by Black and then by Daly. Okay, so there's some support for the comment that people bipolar who are depressed will respond quicker. But of course, again, you got to watch for them that they don't switch into hypomania or mania. Now, you can do ECT for those who are manic. We often don't prescribe it. It's logistically it's difficult, right? When they're that manic, it is really difficult. But we've done it, and it's usually in cases in which there's been extreme agitation. They've been in the quiet rooms for days on end, and all the meds aren't working, or maybe even making them more delirious. So we've seen that. There's a condition called manic delirium, which is really the nth degree of mania. So if you just keep people, or you let people become manic and then just don't treat them, and a number of them will get to this end point where they look delirious-like, but they don't actually have a physical cause for their delirium. They've got this manic delirium. That responds really well to ECT. Other indications, schizophrenia and related disorders, especially catatonia. I talked about that. I'm going to talk about that a bit more, so I'll just skip that for now. Positive symptoms with abrupt or recent onset, and of course, a history of good response to ECT. As a number of you know, even though this wasn't specified very well in the APA or BC guidelines, that those with treatment refractory schizophrenia could respond to ECT. A lot of the refractory psychosis algorithms will, at the end, as you go down all the different permutations, you can get to the point where ECT is recommended with or without medication. And it's something to consider, and I think the next slide reflects that. For people specifically with schizophrenia, not necessarily with schizoaffective now, that there's some evidence to say that combining pharmacotherapy with ECT can be effective over and above medications alone. And it could help with positive symptoms, psychotic symptoms, probably doesn't help with negative symptoms. and it can help with suicidality or aggression in those with refractory psychosis. There's some evidence for an ECT risperidone combination. There's some evidence, some older literature from India with using ECT and fluphenthixol, I believe, or maybe it was fluphenazine. I can't remember. One of the two, one of the flus. They combined ECT with a conventional antipsychotic and got a better response. The most interesting one that I would invite you to look at is this Petretti study in American Journal, just published, and it was great because it was people who'd been on 8 weeks of clozapine. They were considered resistant because there was no movement in their positive symptom scale scores. And then they randomized half of them to just continue clozapine for 12 weeks or ECT for 12 weeks. And they used bilateral ECT, in this case, 3 times a week for 4 weeks and then twice a week for 4 weeks. And with the average length of ECT being somewhere around 15 for these folks, that they showed in 50% of those who got ECT and clozapine, 50% responded, and they defined the response rate as a reduction in their positive symptom scale scores of 40%, which is quite remarkable. Any of those of you who work with schizophrenia research or know about schizophrenia research, 20% is considered pretty good, but this was a 40% reduction. And there was accompanying on the CGI and CGIS improvements as well. So that was remarkable. And then what they did is people who were in the clozapine group through those whole 20 weeks, they gave them open label ECT and said, hey, you haven't responded, let's give you ECT. So in that arm that only got clozapine, then they gave them ECT, and 50% of those people responded. So that is quite remarkable. I think it speaks for the power of combining medications, and certainly in a highly resistant population of those who suffer from schizophrenia, clozapine and ECT as being a combination, as potentially a winning combination. Secondary indications. I'm going to go through the two up here at more length, but you can actually have people with Parkinson's disease, and you can have ECT being effective for the motor manifestations of Parkinson's as well as its psychiatric manifestations. Mood disorder, secondary physical illness, delirium, and intractable status epilepticus. So these would be in the BC guidelines, secondary indications. Catatonia and NMS. The reason I'm going to talk about that at some length is that this is going to be the times when they're going to call you as ECT practitioners. They're going to call you about somebody who they think is catatonic, maybe not, maybe yes, maybe they're NMS, they're not sure. And so I think you really need to know about this in more detail. With catatonia, there's been a couple of important reviews on the topic. And of course, we would try benzodiazepines first, and the recommendations would be a course of benzos, usually lorazepam, preferably lorazepam probably, because it's believed that catatonia is mediated through GABA A mechanisms, and lorazepam is very specific to GABA A, whereas GABA B, such as clonazepam, hits both GABA A and GABA B, theoretically may be less effective because GABA B, if you hit that, you can actually worsen catatonia. The prototype for that is baclofen, which hits GABA B only. You trial lorazepam for 48, 72 hours, and if it doesn't work, then you would consider ECT. And I think one thing that one should think about is that the most common cause for people going into a catatonic state is not schizophrenia, it's actually mania, it's actually a bipolar illness. So that's something to consider when you see somebody who's catatonic. Okay. So this is, yes. Sure.
It is something that I've said before, that the most common cause of catatonia overall is not psychosis, but affective.
Yeah, bipolar.
Would that have any implications on your management in those first few days? Would you ever consider lifting it more antibiotics or something like that?
Yeah. So, the question is, if somebody has catatonia and you think, well, there's an established history of bipolar illness prior, or you're just not sure, because that makes a difference. If there's established, then you would consider it, but if it's not clear, then I don't think that one would necessarily think about introducing lithium or valproate in those circumstances. Does that make sense?
Yeah, it just leads to the question of what the management implication then is of thinking there may be a mood basis for the catatonia in those first few days.
Yeah, it's a good question. I don't know the answer to that, but I think that it's quite possible that that could work. I just don't know of any evidence around that using those. What I do know, though, is that there's two forms of catatonia, right? There's the non-malignant and then the malignant catatonia, which is also called lethal catatonia. So the graph, which I hope shows up well on your handout, divides up what you would do. They're different approaches. If you got somebody who's got malignant catatonia, they can look NMS-like. They can have autonomic instability. They can die from it. And at that point, you would actually not use any antipsychotic. You would stop all antipsychotics. Whereas if they are catatonic, there is some evidence to support that you use atypical antipsychotics in that state, along with the benzodiazepines. Okay, so not so much lithium and valproate. But I think a lot of people just use benzos in that situation. And you can ramp it up pretty high, the benzos, if you truly think this is catatonia. But you can see at the end of the day, for both the non-malignant or malignant forms, you're basically looking at ECT. Okay, so that's catatonia. Just remember that there's a differential to catatonia. There's NMS. Talk about that in a sec. Anticholinergic delirium, manic delirium, serotonin syndrome, malignant hyperthermia, and the list goes on, as you can see there. Okay, so I think the three major ones probably to distinguish is going to be NMS, anticholinergic, manic delirium, and actually the fourth one is serotonin syndrome. So there's certain ways that you can try to distinguish between each, which I won't go into in any detail here. NMS, the article by Strawn in the American Journal, I think is still a classic article. It gives an idea of what the mechanisms are, what the clinical manifestations are, what are the lab values you kind of follow. For instance, they talk about how in NMS, one of the things you might look at is a serum iron. They have people with NMS can have low serum iron, and it might be one of the markers that you think, well, this is NMS. And they also had a table which may or may not show up well. Hopefully shows up okay in your handout, that at stage 4 or 5 of NMS, moderate or severe NMS, in general, these are going to be people who have moderate to severe rigidity and a temperature. You would look at considering ECT in those circumstances. Okay. I think what makes it kind of difficult is that some people with catatonia, as I said before, can have autonomic instability. They can actually look NMS-like. Similarly, people with NMS can actually have catatonic features too that may come and go. So it's not that easy sometimes distinguishing between the two. What we do know is ECT is effective. Lorazepam may actually help with NMS, maybe not on its own, but just it could help as well. And in this by Mann in '86, this series of 300 like they did a Medline review of all the lethal catatonia cases prior to that. That were published since 1960. They were unable to distinguish catatonia from NMS in 22% of patients. So it can become a clinical conundrum. I mean, the good thing is that we know that ECT can help, but you do slightly different things depending if it's catatonia or NMS. But fortunately, and I've actually used the service before, there is this NMS information service, and they're a group of outstanding ECT researchers, researchers for catatonia, NMS. I mean, there's a group of these people that you can actually get on the phone. So it's nice, if you have a really unusual case and you're not sure, you can give them a call. I mean, you don't have to talk ECT with them. It could be just a difficult case. A lot of these people are very knowledgeable about ECT, but you could actually give them a call. So something for you to know about. The physiological effects I'm going to briefly go through, and perhaps my colleagues speaking today will also talk about this as well, because certainly with the medical risks, a lot of the medical risks that come up with ECT will be as a result of the physiological effect of ECT. So any of you who've done ECT have probably seen this, right? Parasympathetic parasympathetic response with the ECT stimulus, and it can be to the point where people have asystole, usually not for a long length of time, maybe up to 3 to 6 seconds, but it can occur. And then you can also get a direct clenching jaw, which also produces a Valsalva type of maneuver, which also enhances the parasympathetic response. Then you've got the seizure induction, and with that is a sympathetic surge. So that's only if you get a successful seizure induction. You get a sympathetic surge, and you can see there's all this autonomic response, but also it increases cerebral blood flow, increased intracranial pressure, and decreased blood-brain barrier. So for up to minutes to hours, you can actually have more permeability of medications or just things in general, through the blood-brain barrier. You can also have increased intraocular pressure, which could be an issue in those with narrow-angle glaucoma, increased intragastric pressure, so you get the risk of reflux and aspiration. And then finally, post-seizure induction, there's times very occasionally, like this happened like once every month or two, that you can see this late parasympathetic outflow. And if they're on beta blockers, pre-treated with beta blockers, maybe you're going to get that a bit more. But sometimes we've seen that where people go kind of, they have the parasympathetic, go bradycardic, then they have the sympathetic surge, and then if you wait another minute or two, their heart rate drops again to like in the 20 to 40 range I've seen. So that can happen. Okay, so I think we're doing good with time. Maybe before I go on to mechanism, yes. John.
Peter, is there any changes in electrolytes with potassium or post-ECT or during?
Is there changes with electrolytes like potassium post-ECT? There can be. It is because of the muscle contraction. If you've got normal kidney function or even impaired kidney function, I mean, it shouldn't go up to any substantial point, right? But there is an efflux of potassium transiently, and that's going to be even more of an issue if people have there's several conditions that make that potassium efflux an issue. So people with a lot of burns, people who have paraplegia or quadriplegia because their muscles are inactive, and what happens is that when you do have a ECT, there's a huge efflux of potassium in these more atrophied muscles, and so there's going to be some conditions that makes that potassium efflux a concern.
I think just where it's important is I think we had one time a patient who wasn't eating and his potassium was low. And I think we ran into some arrhythmia problems.
So you're thinking more low potassium?
Yeah.
I see. So with hypokalemia, I mean, clearly with hypokalemia, hyponatremia, hypomagnesemia, hypocalcemia, all those lights, if they're low, can increase the seizure duration. And maybe even give you a prolonged seizure. I mean, it just makes the CNS more excitable. So there's a risk of prolonged seizure in those circumstances. So definitely want to correct. From a cardiac point of view, of course, too, like they're maybe more prone to arrhythmias, post-ECT. So you'd want to try to correct all of that. Any other questions? Yes.
I wonder if you can make a quick comment on tardive seizures.
Tardive seizures. Can I just, so I know specifically what you're referring to, can you explain that a little bit?
It's usually seizures that happen, Say, for example, for patients who have been discharged post-ECT and they have seizures whilst at home
Yeah.
or on the ward?
Yeah, that's extremely rare, fortunately, and that's part of the reason why we want a responsible person to pick them up and supervise them, and they shouldn't drive, et cetera, right? It's really rare. Um, we've had one even in the past year where she has epilepsy, and we had to adjust the anticonvulsant doses for her in order to get the ECT going. And maybe Dr. Doyley, who just walked into the room, will be able to talk about more about that case. This is one of Dr. Doyley's case of somebody who, had a seizure, in regards to, in a very difficult, challenging case, right? Because she was very depressed, and there was, having to drop the anticonvulsant dose with the help of neurology, drop it to a certain point, but then there was a tardive seizure. The topic's tardive seizures, and I've had that too happen on a case from way back. So it can happen, but generally it's going to be in those that are have epilepsy to begin with. But one of the things that you might, so I wasn't sure if you were talking about this, is that in the post-ECT period, you can have just in the PAR there, you can actually have non-convulsive status epilepticus. So people kind of seemingly come out of ECT and seem to be wakening, and then they kind of go back into what looks like almost like a sleepiness, but it kind of fluctuates, and they may even have like some involuntary movements, and you're kind of wondering what that is. And the best thing is to actually slap the EEG electrodes back on to make sure they're not in status. But you can get status without the full motor manifestations. So you want to, make sure that that's not the case. And that, there is, when I talk about non-convulsive status epilepticus with ECT, there's some literature on that I invite people to have a look at. But yeah, I think that the most challenging cases are the ones that have epilepsy to begin with, and you're trying to get an effective seizure or just any seizure, and that's where we have tardive seizure. Have you had something like that, a situation like that?
No, I was just reading about it.
Yeah. Mechanisms. Okay, so I'm going to spend about a few minutes on mechanisms. The bottom line, we absolutely don't know what ECT does. I mean, I think what I'm going to talk about is some theories around how depression works. I invite you, if you're wanting to learn more, there's a whole issue of Journal of ECT in June is devoted to mechanisms. Mechanisms maybe around psychosis and how it's treated, Parkinson's and how it's treated. So I'm only going to talk about the depression part. What's emerging with the development of depression, as summarized in this in this graph, is that you have like the monoamines, then you've got the the corticotropin and ACTH and cortisol axis, right? The HPA axis. Then you've got cytokines potentially now being in the picture. The whole idea of pro-inflammatory cytokines, which may provoke depression. Then you've got the BDNF story, which I would think you've heard of. And ECT may affect each and one of these, but it's not clear as a unifying hypothesis why ECT works. In terms of what ECT does, it does some things that are similar to what antidepressants do, but it does some things that are totally different. So therefore, there's no unifying hypothesis around how it affects monoamines as well as other neurochemical systems like GABA or glutamate. So that's summarized in your handout. Other theories, BDNF, just list them all here. So there's the BDNF theory, talk a little bit more about that. We know that depression can decrease levels of BDNF and cause, especially in the hippocampal areas, decreased volume and other areas as well, the prefrontal areas. There's this theory that ECT tries to restore the rhythms of what are central diencephalic functions, hypothalamic functions. that regulate certain things like sleep and appetite and those sort of hypothalamic functions. There can be changes in cerebral blood flow with ECT, which may be a reason why it's effective. And there's now this connectivity hypothesis that's come up, and then even inflammatory modulators. So invite for people to look at this most recent article in December if you really want to get into the minutia of how pro-inflammatory cytokines may cause depression and how not necessarily ECT, but just anything that modifies BDNF could actually help with the inflammatory cytokine effect in the central nervous system. So in regards to the BDNF evidence, unfortunately at this point it's a little bit contradictory. It's not that clear. However, I think the majority of the studies are saying that BDNF levels increases in the brain, especially in certain areas of the brain with ECT. Clearly with ECT, you can get hippocampal neurogenesis and dendritic sprouting and all that kind of thing. That can occur with ECT, both in the laboratory and also with humans. Just to remind people in terms of the limbic structures, so you've got the dorsolateral prefrontal cortex, the orbital medial frontal cortex, the ventral medial frontal cortex, the anterior cingulate gyrus, and the amygdala. So those are important parts of the limbic system which ECT can target, and but not very specifically. When we do TMS, for instance, we try to tap into the system by targeting the dorsolateral prefrontal cortex specifically by increasing the brain metabolism in the site by doing high frequency RTMS, for instance. But the mechanisms for RTMS may be different than those for why ECT has an effect. This earlier study from Nobler had talked about how with ECT and those who respond to ECT, and this is bilateral ECT now, that there's decreased regional cerebral glucose metabolism on PET at frontal and parietal cortex, anterior posterior cingulate gyrus, and left temporal cortex, which is over here. It's a little hard to see, but this would be the cingulate areas here. This part here and this part here would be more the left temporal cortex, and then also the frontal and parietal cortices as well. So it does affect brain metabolism changes. It's not clear though whether there is an epiphenomenon of the ECT, or is this an actual effect that causes a positive change. And finally, because this is becoming increasingly more and more minutia-like, the connectivity hypothesis is the most recent theory around this. And you may have heard about this for depression, for schizophrenia even. Like I think the idea that certain areas are either coupled too tightly or too loosely in their connections, so that by altering the metabolism or the function of one area, you affect the change in the other. And there are a couple of hypotheses around that. I'm not going to go into them. I mean, this is more for your information to look at further. But what it comes down to is that there's a theory that depression might be caused in part by too tight connectivity between certain regions and the dorsolateral prefrontal cortex, especially the left side. And that with ECT, and some of the studies seem to have shown this, that you can have less functional connectivity between these areas. And so as we have more and more studies on this topic, especially like better neuroimaging, like MRI diffuser attention imaging, DTI, we're going to be able to, I think, quantify and show, whether there is truly an effect with ECT in these areas. Now, I was asked in the last little bit to talk about what's upcoming. And what's upcoming is that there's a group of us, Caroline Gosselin, myself, Wei Song, Cletus Okwando, and somebody else who I can't, sorry, forgot the name of, but who trained in Ireland, but is practicing here in BC. We're a group that is trying to look at a draft document for provincial credentialing of ECT. This is part of a whole set of provincial credentialing criteria that people are looking at, not just for ECT, but for geriatrics, for child and adolescents. You know, it's going to be actually very wide-ranging. But for the ECT portion, we're working on how does one get initial credentialing to do ECT? How does one renew privileges once you've been granted? And you know, if you've taken some time off, you know, say you go on a big mat leave or do a 2-year sabbatical and you want to come back and you want to do ECT after having done it for a while, what's the criteria for getting your privileges back? So, you know, the initial privileging is still being worked out, so I'm not going to show that here. It's not entirely clear at this point. It's still in review. What I can show you is the renewal of privileges, and it looks like that it's going to be, in order to maintain privileges for ECT, that you're going to need a minimum of 8 individual treatments per year averaged over the previous 36 months. So you can see that's relatively low bar, I would think, anyways, for most practitioners in order to renew or regain your privileges based on just doing ECT. However, you also need to have proof of annual maintenance, and you know, that can be in the form of rounds or whatnot. We offer also at the CPA a ECT update course for practitioners, and that would be considered acceptable, or any other conference on ECT or any other updates that one chooses. So that's for renewing, and then this is a bit wordy, but really what it comes down to, if you've taken some time off and you want to get your privileges back and you want to do ECT again, assuming that you've had privileges before, then you need to have a recent attendance of an ECT course, including a practicum at a university or full-day certification course in the US. Or you have to work with your head of the department of ECT in your hospital or even within your region. If you don't have a hospital head for ECT in your hospital, you would work with the regional head in order to have a full day, minimum 6 hours review of all aspects of ECT, including all this stuff, and supervision of independent delivery of at least 4 ECT treatments by the designated head of that department, or if it's delegated to someone else, and then by that person. Is that clear? This is coming. It's coming as part of this wider process of credentialing, and the college is quite involved with this. I think certain members of the audience are as well. Nigel, are you part of that? It's something that we're going to see, I would think, in the next year, is credentialing provincially as opposed to just health authority based. With that, I leave you with just a few articles that you might find helpful. Thank you very much. I think we've got time for 5 minutes or so for questions, if anybody has any questions. Yes. Hi, Barbara. Well, I think stopping the ECT would certainly be one of the options. And I think I'm thinking about the epileptics, who we've had that have had the tardive seizure. And so, that is one of the options, because it would be considered just maybe too risky to do the ECT. On the other hand, if somebody had a tardive seizure and there's no underlying condition that you can identify, I think one would need to just make sure that there aren't any predisposing factors that could have been part of why they had a tardive seizure. So in other words, electrolytes, for instance, which we often do baseline, right, before the treatment start, but we often don't follow it during the course. I mean, we'd want to just do electrolytes. We'd want to see, like, with the treatment itself, was there anything unusual about that treatment that was different than the previous treatment? Like, for instance, did the dosage go up on it? So those would be some of the factors that come to mind. I don't know, anybody in the audience can help me out, like what other factors one might think to look at. Because it'd be a shame to say that this person, shouldn't have ECT, right? Because oftentimes the options are then going to be quite limited, based on that. I think that if they were outpatients, clearly you'd want to not do it as an outpatient, you'd do it as an inpatient. But if they're inpatients, then there's a question of what to do. Yes?
Hi, I wanted to ask you if you could comment on the reading and evaluation of the duration of the seizure. For instance, if with bitemporal ECT, we are recording, let's say, unilateral seizure, should it be without generalized tonic-clonic contractions, so that could be just added on or generally, EEG reading during the ECT, is there any kind of literature that you could advise?
So if I heard this correctly, it is to do with, your question has to do with in terms of using bilateral ECT?
Yes.
And it would be people who seem to have no tonic-clonic response.
Yes, but they are EEG, sometimes not really typical seizure changes, spike and waves, or sometimes spike and wave, but on the one side only.
Okay.
Can that be considered a seizure response, and how?
Well, I tell you, the most sensitive way to know is that there is an autonomic response where there's a sympathetic surge. So if the person's heart rate, after you've done the stimulus, right, I talked about the parasympathetic response, but after that, if their heart rate sort of goes back to what it was at prior to the stimulus, then unlikely that there's something that happened. But if it goes up, and especially if the blood pressure goes up, but of course you don't take blood pressure in real time, right? It kind of cycles. Heart rate is the most, I think, sensitive indicator. If it goes up to a significant degree, you probably did have a seizure, irrespective of what's showing on the EEG or what's showing motor ictally. Okay, so that would be one comment. If there's no tonic-clonic, you kind of wonder if there's too much succinylcholine aboard, and it might be something to modify later, down the road, the next time, or use a cuff technique or something, right, to try to see a bit of motor. But I mean, I think we've all probably been, who've done ECT, been in those circumstances where you're kind of wondering if there's an actual seizure going on here. And I would say that, if it does look like there's some spike waves, whether it's one side or the other, and then it kind of flattens out and there's a change, then there probably was a seizure. And especially if there's an autonomic response accompanying that, i.e. a sympathetic response. If you had no seizure, then you're not going to get a sympathetic response.
And just in addition to that, if there is a non-continuous spike and wave changes on the EEG, in other words, there is some, let's say, some seconds, 20 seconds, let's say, and then there is a interval, and then there is a run for another 5 seconds.
Yeah.
How would you, and generally, is it valid or it's just,
Yeah, I'm not aware of any specific guidelines around that. I think most of us would say that if there's like a 2 to 3 second stretch of no ictal activity, we would call it at that point in time. That doesn't mean that people don't go into more bursts and maybe even have runs of seizure activity, but we call it at when it flattens out, or at least there seems to be some suppression for that period of time. I mean, if it keeps coming back, then of course you'd have to watch, and just continue and monitor, because there can be people very, very occasionally who have these little pauses in their seizure activity, then they keep on going again. So you have to watch for that. But I don't, like a lot of the ECT practitioners here that I work with, 2, 3 seconds, 5 seconds, what do people do? 5? 5, we got a 5, any? 5? Anybody else? Okay. Well, I guess I'm a quick kind of guy. I'm more than 3 seconds. Let's get out of there. But there's no standard as far as I can see from the guide. Like what you would wait for on an EEG. But 5 seconds would certainly be considered a good time. Yes. Last question.
So once the seizure disorder that needs ECT, for how long would you normally stop the anti-seizure medication?
So the question about anticonvulsants in somebody with epilepsy. The guidelines, including the most updated UK ones, say that in general it's fine to continue anticonvulsants if they have bipolar disorder or you're using the anticonvulsants for psychiatric reasons. Sorry, it's the other way around. It's if they have like bipolar disorder or something that you've got the anticonvulsants, you should try to reduce it or stop it. But if they have a seizure disorder, you should try to continue it. My apologies there. So with seizure disorder, you should probably try to continue it. But I think what happens is that there can be a concern about, as mentioned earlier, like how we can get an effective stimulus, right, with those on anticonvulsants. So generally speaking, for those with epilepsy, I don't routinely stop the medications or even to hold it the night before. My colleagues may differ on that. I've had a case, this was like maybe 14, 15 years ago. They were on 3 types of anticonvulsants. They had a bad seizure disorder. And at the time, the guidelines were hold the anticonvulsants the night before and the morning of, which we did. And in pre-op, the patient had a seizure. Was fine, like had a short, 30-second seizure. And, I think that, once burned, twice shy kind of thing. I think if especially if they're on multiple anticonvulsants for their epilepsy, be really loath to try to make a change with that. However, during the course of ECT, or if you can't get anything on the first treatment, any kind of a response at maximum settings, then I think you're going to have to start having to do something with that anticonvulsant for epilepsy. But generally speaking, for anticonvulsants for non-epileptic purposes, you would try to hold it the night before and the morning of. Does that answer your question? Yeah. Yes. Oh, are we out of time? I'm sorry. I don't want to take up from. Do you want me to field one more question? Because it's. Yeah. One more question. Dr. Unger.
Hopefully a quick question. Just in the previous study with the ultra-resistant schizophrenia patients, I saw that they used 1.5 suprathreshold stimuli. Is there any suggestion that we should be doing ECT in different ways for the different indications? Rather than 2.
I think the studies with treating schizophrenia have been bilateral, bitemporal, but there have been some bifrontal studies. In my opinion, I don't think right unilateral should be looked at in that situation. So it's a very good point that you brought up. I think that whether bitemporal does any more than bifrontal, I don't know the answer to. If you talk to Dr. Fidel Villa-Rodriguez, who's the academic head of the psychosis, or the academic head of the psychosis program at the university, he thinks that bifrontal could work, and he's talking about a couple of studies he's seen. So you could probably do either, but I would certainly defer to somebody like Dr. Villa, who does this a lot more on the actual comment. Would you go 1.5 times? Yeah, I would do that, 1.5, 2 times in that range. You'll see in that article that they interestingly used a thimerotron DGX, which has a very high pulse width. It's like 1.5 or something. Like it's a high pulse width. So it's not your standard machine that we tend to use for brief pulse or for ultra brief pulse. Thank you.
So I'll introduce Dr. Michael Shabbatz, who will be speaking on assessing ECT risk. So Dr. Shabbatz is a psychiatrist at Richmond General Hospital, and he works on the inpatient unit as well as the mental health team there, as well as being the medical director for the ECT service. And he's also a UBC clinical assistant professor. And I'll welcome him to the podium.
Is this microphone working? Yeah, great. Well, thank you for inviting me here today. This is my first time at Surrey Memorial Hospital, and I just have to say I was just stunned by just what a beautiful building you have here, and it's really a lovely campus, and I appreciate you inviting me here today. I think this is going to be a great day for you looking at ECT. I enjoyed listening to Peter's talk. It was very interesting, of course. I am a psychiatrist, and I am at Richmond. Richmond Hospital is, a little bit smaller hospital than some of the main hospitals in Vancouver. We have about 35 inpatient beds split between our sort of CREST equivalent and the hospital, and we look after about 200,000 people, or serve a population of about 200,000 people. I've been there on staff since I completed my residency about 10 years ago now. We have a relatively smaller ECT program. We generally do somewhere between 200 and 300 cases per year. It's not a big service there. I'm the primary ECT practitioner in Richmond. I've had the privilege of being part of the group that teaches the ECT course for our residents. I think they primarily do it as part of their PGY3 year in their residency, and I've been giving a talk similar to this now for a few years now, and I've quite enjoyed it, and appreciate coming here to talk a little bit about the same thing today. What I hope to talk about today is about the risk assessment for ECT. I'm going to talk a little bit about the evaluation or pre-ECT workup that I think we all should be considering before we embark on a course of ECT. And then finally, I have a few special populations that I'm going to talk about for ECT, and these include pregnant women, the child and adolescent population, and also those with personality disorders. So in medicine, we often talk about contraindications in regards to therapeutic interventions, be it medications, investigations, such as the use of contrast dye and X-ray or other radiology investigations, or surgery. I think although these concepts remain important for ECT, I'd suggest that the more important concepts to focus on are the relative contraindications and their assessment through something we call risk assessment. I think much of the literature that I like reading about anyways speaks about the concept of substantially increased risk. Now, the 2010 position paper issued by the Canadian Psychiatric Association included a statement stating that there were no absolute contraindications to ECT. but importantly qualifies that statement with this, which I really like the wording of this, in which they state there are numerous medical conditions that may increase the otherwise low level of risk associated with ECT. Consequently, I think that the better term is that of risk assessment, in which the approach would be that the referring and consulting practitioners approach the decision to proceed with ECT by considering the associated risk and potential benefits along a spectrum. Indeed, there can be situations in which ECT might be delayed in order to address or treat some underlying medical condition, or when we might even decide to forego ECT simply because of the poor risk-benefit profile. But I'd suggest that latter one is actually not particularly common overall. I think for the most part, we're able to address some of those underlying medical concerns and indeed proceed with ECT. So when it comes to the risk associated with ECT, there's really three main organ systems which have been associated or which have been shown to be most associated with negative outcomes in ECT. I think primarily these are the cardiovascular system overall when you look at the literature, but also the central nervous and pulmonary systems as well have been associated with negative outcomes with ECT. So this next slide offers more information in regards to some of those conditions which are associated with substantially increased risk. This list is taken from the American Psychiatric Association's task force on ECT, and Peter referred to this in his talk. And they issued a book, and I have it. I think most people who do ECT should have this book as well. Indeed, it is a bit dated. It dates back to 2001, and I do hope they issue an updated version soon. But it still remains quite a highly influential statement in the literature. Indeed, the 2002 guidelines, when they talk about some of their risk, these are the BC guidelines. I think for the most part take a lot of the data from there and include it in their table as well for conditions associated with substantially increased risk. There's a lot of more recent guidelines out of some of the U.S. states on ECT, as well as some of the more recent publications reviewing ECT still refer to these conditions or this list for conditions. So I think just to highlight some of them here, they talk about unstable or severe cardiovascular conditions. I'm going to try and talk a little bit more about those in a few future slides, just to give a little bit of an idea of what I think you should think about with that. They talk a lot about coronary artery disease, congestive heart failure, and severe valvular disease. I'll talk a little bit about what recent might mean to you or to me. We talk about aneurysms or vascular malformations, increased intracranial pressure, a recent cerebral infarction, and I'll talk a little bit about what recent might mean to some authors. This is COPD, asthma, pulmonary conditions, or even active pneumonia. And this last one, it's not aspirin. It's the American Society of Anesthesiologists, and they have a rating scale that they use to talk a little bit about physical status of patients in their assessments. And I'll talk a little bit more about or introduce what that scale means to you in a few slides down the road. So now what I'm going to do is I'm going to talk a little bit about each of these conditions separately. So many would suggest that cardiovascular complications are of paramount concern with ECT. The 2009 paper that you can find in the New England Journal of Medicine by Tess and Smetana reviewed ECT from a general medicine and primary care point of view. And it's really a great paper. I think, Peter, you had it on your list of references there, and it's sort of one of the golden articles that we hand out to the residents in our course. And I think it's an excellent paper, and they actually concluded in their paper and put out this statement, which I thought was quite helpful, that although the American College of Cardiology and the American Heart Association guidelines do not directly mention ECT, the authors believe that ECT is analogous to a low-risk procedure because of the short duration of anesthesia, the absence of significant fluid shifts, and the relatively low rate of major cardiac complications. These papers suggest that active cardiac conditions will require further investigations or treatment, but for the most part, once those conditions are deemed stable, ECT can proceed. To gain a better perspective on the cardiovascular risk associated with ECT, I've included a graph here that's found in Richard Abrams' 2002 book on ECT. I think this is really a great slide, and I'm just going to talk through it a little bit because I think it'll really just help emphasize why we're concerned in the cardiovascular system in terms of risk with ECT. So just to look at the graph here, on the y-axis here, they're referring of units of heart rate and blood pressure, and the blood pressure in millimeters of mercury. Along the x-axis here is time in minutes. The top graph here is showing blood pressure. The bottom graph here is heart rate. And then this bar graph here in the dark shaded area here, this is actually the delivery of ECT stimulus. And then in the more white part here is the actual seizure itself. So what happens when we actually go ahead and give the delivery of the stimulus and the electricity? So initially, I think you'll see a vagal-mediated parasympathetic outflow. And along with that, you'll see a drop in blood pressure as well as heart rate. The blood pressure drop, I don't think is quite as impressive, and it's not something you'll actually see quite as quickly because of the delay in being measured, but you can see the heart rate and changes as well. Along with that, in some people, the heart rate changes can actually be quite significant. There's often a bradycardia seen, and I think in more vulnerable patients, you can actually see asystole. Now, this was a paper that's now about 15 years old, and these authors took a sort of an open case series of ECT patients in a geriatric group, where they actually reported that 2/3 of them had an asystole of more than 5 seconds. And to be honest, I think that's quite a significant overestimation of what we usually see with ECT. But I think it does highlight that in some of the more vulnerable people, this bradycardia or even asystole can be quite significant. Following the vagal parasympathetic outflow, you'll see a rebound sympathetic discharge. Now, it's initially mediated in the seizure itself through the hypothalamus, following through the sympathetic system directly to the heart, which will cause increased heart rate and contractility but also through neuroendocrine systems, you'll actually get stimulation of the adrenal gland itself and catecholamine release. And along with that, you'll see a real surge in both blood pressure as well as heart rate. And that actually can be quite significant. There are some studies there that talk about a 25% increase in mean arterial pressure, perhaps maybe a 30 to 40% increase in just blood pressure overall in another study, and maybe up to a 52% increase in heart rate. So for some people, that can actually be quite significant. And that's really where I think a lot of the cardiovascular risk associated with ECT comes from. Now, fortunately, these changes are not really long. The comment that most changes resolve within 20 minutes is from one of those articles. And I think, initially we'll see the vast majority of the changes in heart rate and blood pressure will resolve quite soon after the seizure itself, and 20 minutes might be a little long, but I think as Peter had mentioned is perhaps maybe just a little bit, this is shown here where he was talking about maybe a little bit more latent parasympathetic outflow again. And that's where you can see here where there's this other change in lowering in heart rate and blood pressure that you might see 1 or 2 minutes out after ECT. Right. So in terms of consequences, it used to be that many years ago, most people getting ECT would actually be pre-treated with atropine to try and mediate this parasympathetic outflow. I don't think that's really commonly being used anymore. The exception might be in someone who has really a catastrophic bradycardia that maybe the next time they come in, they'll be given some atropine or other anticholinergic agent. But I think in terms of what our anesthetist colleagues are doing to help protect our patients against cardiovascular risk is really associated with giving medications maybe to attenuate these surges here. And so this is where you'll much more commonly see beta blockers being used during ECT, labetalol, esmolol seems to be a local favorite at my site, but I think there's a lot of other ones that are used elsewhere as well. So in terms of cardiac conditions, I think it's safe to say that ECT has been safely performed in nearly all cardiac conditions, provided they are deemed stable. The literature really points to increased risk associated with unstable or active cardiac conditions. Now, in regards to the literature, there was this comment about recent myocardial infarction, and it's often mentioned as somewhere between maybe 30 days and 3 months would be defined as a recent myocardial infarction. I think as psychiatrists, we worry a lot about our patients' medical status, and so probably for our terms, in terms of our investigations, we might choose 3 months as being defined as a recent MI. It doesn't mean you can't do ECT, but I think it certainly should bring to your attention about how you're going to investigate and risk stratify about where you go ahead. And it might be a flag for perhaps in internal medicine or cardiology consultation for an opinion about how we should manage this or proceed. Now, the timeline, though, for myocardial infarction may not necessarily be quite as important as what's left after they've had their MI. I'm sure you can imagine that someone with an MI a little bit more remotely, but ongoing vascular insufficiency and perhaps some anginal symptoms would certainly be at increased risk, even though their MI might be a little bit more remote, just in terms of the timeline. Now, when it comes to angina, they talk about sort of unstable or severe angina, and what does that mean? Like, how stable or unstable is stable? And so there's a paper published in the Journal of ECT last year talking again about medical complications of ECT. And they kind of quoted sort of looking at a functional assessment. And sort of the threshold that they looked at was something that they called 4 METs, or metabolic equivalence. And what is a 4 METs? Well, they said that it's approximately walking up a flight of stairs, or perhaps walking on the level at sort of a brisk walk, which they say is about 4 miles per hour. And if you're developing some anginal symptoms on that, they would define that as being a little bit higher risk of angina and would certainly warrant further investigations. I think, though, for the most part, this type of assessment is really beyond the scope of practice for most psychiatrists, me included. For my own practice, about saying whether you want to invite in a cardiologist or an internist to look at heart disease, I would sort of ballpark it if I have patients that are sort of meeting those criteria, I might directly go and ask for a cardiac consultation even before looking at ECT. But in cases where I'm not so sure, I might rely upon my anesthesiologist colleague who comes in for their routine pre-op consultation to guide us a little bit about where we go. Yes, sir.
seems like an obvious concern that in someone with a recent MI or unstable angina that there would be a risk of a further event with ECT. Is there any evidence to support that?
Yeah, I think probably the question was that is there actually evidence to support a risk of another myocardial infarction in someone with sort of a recent MI? Do I have your question?
Yeah, or exacerbation of angina in someone with previous angina or unstable angina.
Yeah, I think there are lots of case reports in the literature that do report cardiac events in these cases. Most of the case reports, people tend to publish success stories rather than negative outcomes, though, but certainly there have been numerous case reports of people doing ECT successfully after a recent MI. That 2014 paper I mentioned as well, I think they actually spoke about someone having ECT 10 days after an MI, but certainly I would say there is ample evidence to suggest that there is an increased risk with that. Does that kind of speak to your question?
Yeah, it does. Thank you.
Okay. So the next thing I wanted to talk about was congestive heart failure, and there are lots of reports of ECT being done successfully in patients with CHF. I think where we start to worry a little bit about the increased risk associated that are really in those that the CHF is poorly compensated. Again, that kind of ballpark, if you have a patient who reports a history of congestive heart failure, how significant is that? Is this stable or unstable? Diligent psychiatrist doing a review of systems, but how am I going to think about this? Well, I think that same sort of 4 MET would be a nice flag for poorly compensated or unstable congestive heart failure again. So if they're walking brisk pace on the level, 4 miles an hour, and they're getting symptoms, or they're going up a flight of stairs and they're getting symptoms, I think that'd be a real flag for unstable congestive heart failure, where the risk with ECT would be considered increased. Again, I think that's pretty easy to assess in terms of looking at management and investigations, but probably we'll be asking one of our consultant colleagues to come in and weigh in on that before we proceed. Okay. So there are a number of cardiac arrhythmias associated with increased risk in ECT, and really these are pretty significant arrhythmias that are listed here. They're talking about quite significant AV block. Third degree heart block is pretty significant. A very symptomatic bradycardia you could include in that list, but also they're talking about symptomatic ventricular arrhythmias, and I think then the one that's probably more common that we'll see is atrial fibrillation, and they talk about poorly controlled atrial fibrillation. Perhaps if the heart rate's greater than 100 beats per minute at rest, that would be a real flag for risk associated with ECT. Generally speaking, for patients who are anticoagulated, you're going to want to follow their INR to make sure that it's within the therapeutic range. But provided that that's okay, you've got a reasonable control of the heart rate. ECT has been done, I think, quite safely in patients with that. There are some reports in the literature just about maybe some spontaneous correction of atrial fibrillation during ECT with the electricity being delivered, and perhaps some risk in some of your uncoagulated patients with atrial fib. Perhaps you might blow off a clot or something in those patients, and so that might warrant a little bit more investigations about what to do in those latter situations. And just to talk a little bit about QT prolongation, there was really an interesting review in the Journal of ECT back in 2011 on QT prolongation in ECT, and I think they looked at about 400 patients, sort of a case series in patients who had prolonged QT and compared it to a control group of people whose QT were within the normal range. They looked at what they talked about cardiac-related events, and that wasn't just exclusively arrhythmias, but it really essentially sort of a little bit wider range of events associated with negative events associated with the heart. And interestingly, they did find that there was an association of increased risk of cardiac-related events with ECT. Kind of what caught my attention, though, was that most of the cases where there was a cardiac-related event, the QT interval was not grossly prolonged. I think we often look at about maybe 500 milliseconds as being really a prolonged QT, but most of the cardiac-related events were sort of in that group between 450 or I think they defined men as 440 as being normal, women as 460, but in those ranges and less than 500 milliseconds. Some problems with the paper, though, was that really the number of cardiac-related events overall was extremely low, and so there wasn't a large sort of absolute number of differences between the groups. But interestingly, in that paper, they pulled out data and they looked at a case series of patients whose QT intervals were much wider than 500 milliseconds. And interestingly, many patients with that wider QT underwent ECT without complication. So when it comes to valvular diseases, the conditions associated with most risk really are when there's sort of a new cardiac murmur or someone who's got symptomatic vascular disease. I think a lot of our patients will have murmurs that are thought to be sort of benign, but it's really the ones that are symptomatic or newer that will really warrant a little bit more investigations. Aortic stenosis can really be of significant concern due to some of the ECT-associated vascular changes in the heart rate and blood pressure. Fortunately, this condition itself has been quite well studied overall in terms of surgical risk, and really there's some very good data and guidelines on what the risk is associated with aortic stenosis taken from echocardiogram studies. And so in patients with that, often you'll be involving a consultant to look at maybe an echocardiogram, and it'll just help you get an opinion as to how significant the aortic stenosis is and how we're going to manage it. Finally, when you think about cardiac pacemakers and implantable cardioverter defibrillators or ICDs, these are not contraindications to ECT. Generally speaking, though, it's going to warrant a referral to our cardiology service. In terms of the pacemakers, it'll probably influence where you actually do ECT. It'll probably require you to do it in a center where you have got the availability of trained staff and equipment such as a magnet to perhaps correct a pacemaker if it's inhibited by ECT itself. Some of the papers have talked about, in certain cases, they might actually do a study of the pacemaker before and after ECT just to make sure that it's working fine afterwards. In terms of the ICDs, the American Society of Anesthesiologists has a recommendation right now that these devices should be adjusted to disable tachyarrhythmia therapies during ECT. There have been some case reports where people haven't bothered to do that without significant income, but right now the ASA recommendation is that we're going to do that. Now, for our purposes, to remember that they've got something metallic in their chest, that doing something for their heart and asking for help is probably where a lot of us are going to err on the side, and then going from there. So along with the cardiovascular response during ECT, one can see some increases in cerebral blood flow. Sometimes up to a third will happen during ECT. And this, along with the increased intracranial pressure and hypertension associated with ECT, really can increase the risk of an ischemic or hemorrhagic stroke in vulnerable people. There's some limited data around this. The New England Journal of Medicine talks a little bit about delaying ECT for about 1 month after an acute stroke. And I think what they're speaking to is that following having an acute stroke event, there are some vascular and tissue reorganization in the brain that does put you at somewhat increased risk of a hemorrhage in ECT. There is an increased risk of ECT delirium in these patients, and also you have to be, of course, a little bit more cautious with blood pressure control during these cases, just to help protect against perhaps having a new event. So increased intracranial pressure is often a time where we're not going to proceed with ECT. We're probably going to look at trying to correct that before we go ahead. And when it comes to intracranial masses, Dr. Kang, they still refer to, I think, a paper you wrote about 10 years ago in some of the reviews. And really what the concern involves is increased intracranial pressure leading to herniation and death. And they always learned about tonsillar herniation in med school. Fortunately, I've never seen it firsthand in one of my patients, but it's still something that we worry a little bit about. There's a 2002 paper in the Psychiatric Clinics of North America that concluded that the presence of an intracranial mass does pose a slight increased risk of neurologic complications in ECT, but in the absence of brain edema, mass effect, or papilledema, the risk is relatively small. So a pre-existing cranial metallic object, such as a deep brain stimulator, cerebral clip or coil, or even a foreign body, as well as a cerebral shunt, such as one of those ventriculoparietal shunts, or maybe a lumbar parietal shunt, would also necessitate a neurosurgical referral. The literature generally consists of case reports around what people are doing with patients with those types of metallic objects. Generally speaking, they talk about using modified ECT placements in certain circumstances. And really what the concern is that the metallic object might disrupt the ECT-induced electrical field. There might be some vascular complications associated with that, and perhaps maybe influencing the seizure duration itself. I think for the most part, though, that there have been many case reports, though, in which we're doing ECT in these patients with some support and guidance from our neurosurgical colleagues without complication, however. I think in a cerebral shunt, it'd be very important just to make sure that the shunt is working properly, such that the increases in intracranial pressure can be handled by the shunt without a significant issue. So patients with a history of traumatic brain injury are at increased risk of some cognitive changes with ECT. There's lots of talk about wanting to avoid stimulating over the skull defect. And this is more of a theoretical concern, but the reasons for this is that the skull itself often offers a lot of resistance to the electricity delivered in ECT. And the thought is that with the skull defect, you might get an increased concentration of electricity in the cerebral tissue directly underneath that defect. So I'd say a known intracranial aneurysm would probably prompt a a referral to either a neurosurgery or neurology service. But certainly it doesn't mean you can't proceed with ECT in these cases, provided you get an opinion supportive of that. Finally, just looking at aortic aneurysms, an abdominal aortic aneurysm would probably warrant further investigation. The concern is that along with the weakened wall, depending on the size of it, would put them at increased risk of rupture during ECT. Fortunately, there is some good literature and opinions that you can get available about how big the aneurysm is. You might do an ultrasound to just qualify how big that aneurysm is, and for people where it's not significant, ECT has been done successfully. But in both cases, of course, blood pressure control would be a little bit more of an issue, and we might be asking our anesthetist colleagues to take that into account with some of their medications that they're giving for the treatment. Finally, in terms of neurologic conditions, there have been some reports of a worsening of multiple sclerosis during ECT, although I think overall the literature suggests that the risk is modest. The risk has been reported to be more significant in those with active cerebral demyelination, and there's been some concern expressed that maybe the succinylcholine itself might play a effect in that role in patients with active disease. Okay. So along with the seizure, you're going to get an increased glucose metabolism and glucose need in the brain, and thus hypoglycemia prior to treatment is really the primary concern in diabetes. In these patients, these are ones that you kind of want to try and do first thing in the morning. If they're on oral hypoglycemic meds, that's when they're going to get them after ECT rather than before ECT in the morning. You're going to want to look at perhaps adjusting the insulin dose. There have been some suggestions that perhaps having the insulin dose or having the long-acting insulin and holding the short-acting insulin the morning of ECT will help mitigate that risk. And then guiding your management by doing the glucose before and then also afterwards during the course of ECT. That'd be with each ECT treatment. In terms of some of the other endocrinological problems, I think generally we're looking at trying to address hyperthyroidism, particularly when it's clinically significant, just through the theoretical risk of creating a thyroid storm with the ECT treatment. Finally, when you're looking at the presence of a pheochromocytoma or in Addison's disease, this will require a little bit extra scrutiny, largely because of the both conditions lending themselves to increased risk of to some of the significant blood pressure or heart rate or blood pressure changes for the Addison and blood pressure and heart rate changes with the pheochromocytoma. Finally, I think someone had talked or asked a little bit about renal disease in ECT earlier, and I think the question came up around hypokalemia, and we talked a little bit about some of the hyperkalemia. And really, when it comes to renal disease, you're looking at people with much more advanced renal disease, and the concern is that along with the motor convulsions, but also the fasciculations with succinylcholine, you do get a little bit of muscle damage and release of potassium, and it does lend the risk of having a bit of hyperkalemia. And I think for the most part, that's really only clinically significant in patients who have end-stage renal disease. I myself had done ECT on a patient who was undergoing hemodialysis because of hemodialysis because of renal disease during the course of ECT, and it was a really tricky thing because we don't have inpatient dialysis in Richmond, and so we were putting her in an ambulance to go get her dialysis done on, I think it was Tuesday, Thursday, and Saturday. But then we were doing ECT Monday, Wednesday, and Friday. It was a very, very interesting clinical case. Our anesthesiology colleagues were monitoring the potassium quite closely with this patient, and what we were doing with this patient is they were doing sort of a stat potassium level first thing in the morning before the patient would come down for ECT, and at the time they sort of had a 5.0 rule, and if the potassium was greater than 5, that would be it for the day. If it was less than 5, then they were doing that, and they were arguing that the potassium surge on average, I think the literature, I found a paper that supported this, is about 0.5 millimole per liter, and so that's sort of why they were picking that 5 range. But we were able to do that course of ECT quite successfully and without complication with that patient. And finally, talking about electrolyte disturbances, Peter had mentioned this in response to a question about hypokalemia and some of the other electrolyte. Those things can be corrected quite quickly by some of our internal medicine colleagues, and so I think it'd be pretty easy to say, but just correct the condition as best you can before going ahead with ECT. And finally, talking a little bit about the volume status of the patient. Many of our depressed patients aren't eating and drinking well, and I think ensuring that their volume status is assessed before they're going down for ECT is quite important, perhaps through measuring ins and outs of the patient, but also we can follow that with serum, urea, and creatinine measurements as well. Again, that latter one is something that can be corrected. Okay. So when it comes to some of the pulmonary disorders, conditions such as chronic obstructive pulmonary disease and asthma, generally speaking, in milder cases, don't tend to lend a lot of risk with ECT, but in more severe cases they can. Many of our colleagues, anesthesiology-wise, are giving some pre-ECT bronchodilators in some of those patients. Pneumonia itself may require the delay of ECT to permit some treatment and recovery of the lung capacity before proceeding with ECT. In terms of a glaucoma, you do get raises in intraocular pressure with ECT as well. It's more, I think it's a theoretical concern in patients with the sort of more open-angle glaucoma, provided their glaucoma is relatively stable and well controlled. I think probably you want to give them their drops before they go down for treatment rather than after to help mitigate that risk. Poorly controlled glaucoma, or the sort of acute angle glaucoma, retinal detachment, those would be ones where we're going to be asking for sort of ophthalmological intervention before considering proceeding with ECT. In terms of hypertension, I think we're trying to get a number of maybe about 140/90 or better in most patients. I think, though, that there's some flexibility in terms of that number, in terms of management and intervention before proceeding with ECT. And then finally, with patients with gastroesophageal reflux disease, along with those, everything else seems to surge. The gastric pressure goes up. There's that Valsalva effect with the tonic convulsion or tonic stage of the treatment, and there is an increased risk of aspiration. I think this just really speaks to the importance of our strict NPO status, which sometimes can be kind of challenging with some of our patients in our psychiatric wards, but also through the use of agents such as ranitidine or maybe a proton pump inhibitor or metoclopramide to help mitigate those risks. So in terms of these next ones here, the osteoporosis, the bony metastases, the post-surgical wounds, or might be healing wounds from someone who may have had a self-induced stab injury through suicide attempt, or fractures as well, which might be part of maybe a suicide attempt and a jump from a high spot. Those might be people where you'd be much more interested to try and intervene with ECT earlier. I think that the main issues with this is just ensuring that they have adequate paralysis is really the paramount concern to avoid convulsive-related injury. There might be some cases where an unstable fracture or maybe a higher risk fracture such as a cervical vertebrae would involve a consultation or perhaps delay or cancellation of ECT depending on the risk in some of those more serious cases. I'll comment a little bit on a report regarding dental injuries later, but these are, of the uncommon risks associated with ECT, these are actually somewhat more relatively common, and they're often just related to inadequate use of the bite block. There's a paper a little bit later I'm going to comment where it speaks to this, but sometimes there's been people using custom prostheses if there's sort of a special unique tooth that's particularly vulnerable for patients. But of course, the removal of dentures and the use of a bite block in the edentulous patient is definitely recommended. Okay, so the last item on the list that I had earlier on was this ASA score. And the ASA, as I mentioned, speaks to the American Society of Anesthesiologists, and the PS is their physical status classification. So in 1940, this was quite some time ago, the predecessor to the ASA, they used to call themselves anesthetists, now they're anesthesiologists, asked a group of 3 physicians to devise a system for the collection and tabulation of statistical data in anesthesia. And really what they were hoping they could do was that they would be able to come up with a sort of an algorithm to define operative risk. However, the authors there kind of concluded that there's no way they were going to be able to do this. And really what they were speaking to is that they were able to comply data on looking at sort of the current physical status of the patient, but they weren't so good at devising the risk of the procedure. And given the vast, variability of what people are being done under anesthesia, they couldn't come up with a model. So instead what they focused on was just a scale to grade the patient in relation to their physical status or their degree of sickness prior to anesthesia. And it was first published in the 1941 journal edition of Anesthesiology. And really and it's been modified a few times over the years. And it's referred to as the ASA physical status. So I think in your handout, I've got this slide a little bit bigger later on if it's hard for you to read on the little tiny ones. It's at the back there somewhere, hopefully. So this is the most recent edition of the ASA physical status scale. I think this one, I got this off the internet, and it's mentioned from October 2014. So an anesthesiologist will often include an ASA score as part of their consultation, representing sort of a global assessment of the patient's current physical state. It's a scale of 1 to 6, with 1 representing a normal, healthy patient, and 5 representing a moribund patient who is not expected to survive without the operation. A few years ago, they added the 6 scale. I don't think it's widely applicable. It's reserved for the brain dead patient whose organs are being used for donor purposes. So I think really it's sort of a class of a 1 to 5 that we're seeing and referring to. And the anesthesiologist sometimes will talk about some of the significant limitations to the use of the scale, and we have the same issues in psychiatry. I think when we talk about global clinical assessment scores and the inter-rater reliability, they have the same issues with this scale as well. But it's often used as part of our risk assessment in ECT, and I think it's a quick reference to provide a global opinion on the patient's physical state. My department head will use it as a quick reference before they come in. They come in and sign off on involuntary ECT, just so they can get sort of a quick idea of what the patient's physical status is before they sign off on involuntary ECT. You'll remember earlier that the American Psychiatric Association really looked or pointed out to an ASA 4 or 5 as being associated with substantially increased risk. However, there have been a lot of some publications that refer to the need for additional precautions in patients with an ASA score of 3 or more. I think an example would be, say, at the Vancouver General Hospital and their neurostimulation program. Generally speaking, they do most of their ECT in this brand new, very nice building, or nicely renovated building at Willow Pavilion. And I don't want to misquote you, Mike, but I think you were saying that if you had an ASA score of 2, you could do it in the Willow Pavilion, but if your score was 3 or higher, you'd be doing it in the PACU. Did I get you right about that? Yeah, and I think that's just because in their site, their ECT suite is separated from the more critical care areas. It's in a separate building. In Richmond, it doesn't really have any influence. We do all of our cases in the post-anesthetic care unit. But I've seen some publications from the UK that talk about similar practices as well. And I think also, if we're getting a suggestion that this ASA score is deteriorating, that it'd be a time for us to kind of look at things about investigating before we go ahead and start ECT. So when it comes to the sort of pre-ECT evaluation, we'll often get a referral to the ECT service in which the referring psychiatrist has sort of come to the conclusion that there's an indication for ECT. Once you've kind of achieved that, as part of that evaluation, we'll be looking at doing, just sort of the standard thing that we do in the emergency department: a medical review of systems, physical examination, as well as some laboratory investigations. Generally speaking, you're going to our local guidelines talk about doing laboratory investigations. I think the BC guideline says within 10 days. I think within 7 days have been found elsewhere. This is really just some standard routine blood work that we're doing. This should have been fasting glucose, I'd suggest. It's a pregnancy screen, if indicated. And generally speaking, you're going to want to have that document on the chart within 7 days. Now, depending on the clinical course of the patient, these might need to be repeated more often. I think it's pretty standard that everyone undergoing ECT these days should have a pre-op anesthesiology consultation. I don't think there'd be a lot of disagreement on that. And then finally, whether there are other consultations needed. I've spoken a little bit about some thoughts I've had about maybe other times when you might want to do that, or perhaps guided by what our anesthesiologist thinks. Interesting. I think this list is a little bit more comprehensive than some of the papers that I've read on ECT screening. Now, points of transfer of care, I think, are really well known as being risk factors for potential negative outcomes. And when it comes to ECT, there is a transfer of care. You've got perhaps an inpatient or outpatient psychiatrist transferring care to the ECT practitioner, and then back again, or the ECT team. And in larger centers, I think it's quite possible that the ECT practitioner might not be familiar with the patient at all before they go ahead and before they even come into the ECT suite. And this is a sort of a one-page form, and I emphasize the one page, but this is something that that we're using in Richmond. I've kind of highlighted twice here just so that there's no ambiguity about who's supposed to fill out the form. It's the attending or referring psychiatrist, and it serves a couple of useful purposes. I think as a quick point of reference in the ECT suite, but also just as a reminder for a referring physician, just to ensure that necessary tasks are to be completed and documented prior to ECT. I think we found it maybe a little bit too onerous to have a whole set of forms, but just did you document a mental status or why you're doing ECT somewhere? Is that adequate? In the Vancouver Coastal Health Authority, there is a working group that's sort of looking at our practice of ECT. It's being led by Fidel Villa Rodriguez. I'm part of that group, and I missed the last meeting because I was away on holidays, but that was where he had presented something similar to this. I think he had added in a clinical global assessment score of the severity of illness, a CGI there. And I think at the last talk we were just discussing whether we were going to submit it to our regional committee for evaluation. So it's something that I find helpful in my own practice. And essentially, I'll tell my colleagues, if you don't fill out the form, or call me after you filled out the form. So, what is the associated mortality on ECT? The American Psychiatric Association, from their 2001 publication, talked about a risk of death of 1 in 10,000 patients, or 1 per 80,000 treatments. The Canadian Psychiatric Association, in their 2010 position paper, sort of had a similar estimate as to the associated mortality. When I'm speaking to my patients and their families about ECT, I do like this APA statement. I like these latter two statements as well, and just sort of helping patients understand a little bit about what it is we're talking about, and suggesting that they embark on. Okay, so I thought it might be helpful to speak about a study published in the Journal of ECT a few years ago, and it was I thought a good paper where they looked at data from the U.S. Department of Veterans Affairs, and I think they were looking at about a 12-year review, and I think it was from 1998 to 2009. It's a retrospective study, and essentially the VA has sort of what they call their National Center for Patient and Safety Data. And essentially, it's sort of a central place where if you have an adverse event, you're supposed to report it. So they looked at this registry, and there's I think 154 veteran affairs facilities across the U.S. I think a limitation to the study was that they actually estimated the number of treatments. They didn't have absolute numbers, which surprised me a bit, but it was an estimate. There were no deaths in their sample size, and there's actually a relatively low harm reported with ECT overall. And interestingly, most of the problems that they found were associated with paralysis, perhaps due to inadequate paralytic agents being used, perhaps not adequate monitoring to ensure paralysis before the procedure was. But one of the more common ones associated in this list were actually the dental, tongue, and lip lacerations. And surprisingly, there were a number of cases where they just forgotten to use a bite block. Or perhaps they hadn't put the bite block in properly. Okay, so this really concludes the majority of my talk focused on the pre-ECT evaluation and risk assessment. It's a bit exhaustive kind of going through this list, and you kind of thinking, oh boy, there's a lot of things I have to worry about before I refer my patient for ECT, or if I'm considering my patient for ECT. But I think overall ECT is a low risk procedure. I think there are some times in which we may have to do some further evaluations and maybe some other investigations or even interventions to try and help mitigate the risk with some colleagues. But really, I think once you have that data, it's common. It's not really common for ECT to be avoided, but it does happen in some cases. Okay. So I wanted to move on now just to some of the special populations that I've been asked to talk about. So there are case reports of ECT being used in all 3 trimesters of the pregnancy, and I think, like with pharmacotherapy, there are some slightly different factors to consider in each trimester. I think there's quite wide support in that an obstetrical consultation is needed. Pregnancy-associated changes place the patient at increased risk of aspiration during ECT. There's this theoretical risk of potential teratogenic effects associated with ECT. I don't think there's really a lot of good data published in terms of what exactly those risks are. The literature comments on some of the teratogenic effects associated with the anesthesia itself as well. And then there are the potential neonatal toxicities associated with treatment in itself, including those sort of vascular changes. You're going to need additional monitoring of the fetus, as well as to do it in a center where you have the resources to manage both obstetrical as well as neonatal emergencies should they arise in ECT. And so I think that's going to really limit where ECT in this population is going to be done. Now, in terms of whether you actually do it in this population is another story, and I have a few things just for you to consider. So, the American Psychiatric Association has published favorable statements about the use and risk of ECT for pregnant women, both in their 2001 task force report, but also in a 2009 report they co-wrote with the American College of Obstetricians and Gynecologists. The CPA paper doesn't directly address pregnancy, but much like the literature pertaining to pharmacotherapy, there are some less favorable statements found around the use of ECT in pregnancy. I think it's fair to say that pregnant women are an uncommon demographic in ECT population. ECT I don't think is widely used in pregnancy, and I think many of the more cases are involving quite significantly ill women that really kind of help tip that risk-benefit profile. So one of the more comprehensive reviews that I found was this 2009 paper in Psychosomatic Medicine, where they reviewed about 339 cases. Like with most ECT, they found the majority of treatments were for depression, similar response rates, and then they listed their complications in terms of the neonatal complications. Some, they spread out what they thought was related to the ECT and what wasn't. There were a couple of deaths associated with it, and then some of the maternal complications. Interesting, this latter paper, and I just added this in because I just found this paper recently, and it was a 2015 paper where the authors, they essentially looked at most of the same data here, but they actually had some methodological differences, and they actually excluded a number of the case reports that they included in here. The cases that they excluded were not the ones with the negative outcomes, and they came up with a much higher child mortality rate and concluded that urgent international guidelines were needed. This is a recent paper. I don't think there's been, it hasn't been subject to a lot of feedback to date. So I would just say that I think the jury is a little bit out on this latter paper. Yes.
Just out of the interest, even in this 2009 paper, what were the actually causes of the complications? I would understand if it would be, let's say, a rupture of placenta or this kind of vascular damage, but what would be the cause of the death of the fetus or the child?
Well, I don't recall them concluding, I think the conclusion was that it was related to the ECT treatment itself, but, what was the exact kind of pathology that caused the death? I don't remember the paper specifically commenting on that.
Because even if the women with epilepsy, genuine epilepsy, hardly ever have any complications to the fetus or to the neonates unless it's a prolonged, as I say, a rupture of placenta is the only kind of a reasonable complication that can be related to that. So, it's a very significant number if we would be telling any pregnant women or the relatives that there might be even 1 in 30 or 1 in 50 risk. That actually would be completely unacceptable. So it's actually very completely opposite of what we have been taught all the time, all along.
I think you make a very good point.
And child mortality as well, if it is 7.1%, do you say it is safe in pregnancy?
Yeah,
we say frequently that it is a safe treatment in pregnancy, but
yeah, I share your concern. I think I'm the point I just make about that last paper is this is just a recent publication. It's just a month old, and so I don't think there's been a lot of opportunity for the research community or the experts in this to kind of
even in 2009 paper, 1 in 30 neonates or infants are going to be affected. Like, how do we call it safe?
Yeah. I think it. I think it just speaks to a lot of the concern that we have in all pregnant women. We have 10 years ago the publications around use of SSRIs in pregnancy were very different than what we've been seeing in more recent years.
Heart rate reduction and uterine contractions and premature labor.
Yes, sir.
We were taught that in pregnancy, if you use anesthetics, there will be more fetal complications. So I think traditionally, they were giving unmodified ECT, though it sounds barbaric, but for the safety of the child. So I wonder actually in this review of 2009, whether they had actually collected patients who had any particular different types of ECT.
I don't believe so. I think the data was taken from about 1970, was sort of the earlier one. So I'd be surprised if they were doing unmodified ECT at that time.
The practice up until 1980 was to give the unmodified ECT. So I don't know actually when the transition occurred.
Yeah. Unmodified ECT in pregnant women up until 1980.
Women. Yeah.
It's a very interesting point. Okay. All right. So just in terms of the children and adolescents, I think it's safe to say that less than 1% of patients undergoing ECT are under the age of 18, In terms of some of our more local experience, at BC Children's Hospital, I believe they do somewhere between 1 and 4 cases per year. So it's not a particularly common procedure being done. There are some states in the U.S. where they've actually have legislation banning ECT. An example is Texas. I think in 1993 they passed a law saying that there is no ECT if you're under the age of 16, which is quite interesting. The literature sort of suggests that there's similar risks associated with ECT and similar response rates. I think the main difference, though, is that on average the sort of referral population is a lot healthier physically than in the adult and older adult group. I think fair enough to say that the seizure threshold is lower in children than it is to adults. The American Academy of Child and Adolescent Psychiatry published some guidelines back in 2004, and their guidelines kind of refer to you needing all 3 criteria listed before ECT can proceed in adolescence. I'll highlight that the guide refers to adolescents. It doesn't refer to children in terms of their guidelines. And I think although the diagnoses are very similar in terms of the indications for adults, the severity and the treatment response are certainly much more significant. They talk about life-threatening a couple of times in their guidelines. And I'll just highlight that this is sort of in contrast to many of the adult guidelines that will often talk about ECT as a first-line treatment in certain circumstances. I don't think that is something that is highlighted in these guidelines at all. I think generally speaking, they're talking about doing at least 2 opinions needed before proceeding with ECT in adolescence, and certainly a lot more scrutiny and evaluation when you're dealing with children under the age of 13. Okay. So the last thing I just wanted to mention, this is my last slide, just has to do with ECT in patients with personality disorders. I think we've all treated major depressive disorder and found the relatively high comorbidity of personality disorders. I think there's quite an interesting paper published about 10 years ago in the American Journal of Psychiatry that looked at remission rates following ECT. And really, they found in their sample size that in patients without a personality disorder, response rate around 70%, which is fairly standard, but quite a dramatic drop in patients with borderline personality disorder, and a little bit more modest drop in patients with other personality disorders. This is, I thought, one of the better papers, this review here. There have been some other papers that sort of suggest all personality disorders predict a lower response. However, there are some methodological concerns with them, and many of them don't actually separate out the different types of personality disorders. And this has influenced my practice in terms of what I'm explaining to patients with borderline personality disorder, in terms of what their potential outcome. And I think it reflects some of the differences that we see in depression with patients with and without personality disorder. I think it is important to highlight that personality disorder is not a contraindication to ECT. I would keep the potential negative effect on response rate in mind. However, it certainly wouldn't prevent you from going ahead and doing ECT in this population. So I want to thank you for your attention and time. This concludes the end of my talk.
Why don't we take a 10-minute break? We start at 11:30, And sorry, Dr. Chavez, for not giving you enough time. My bad. And sorry, Dr. Doi, for not giving you enough time. But we'll start in 11:30. There's coffee and refreshments outside. Very good. Thanks for having me. That was very extensive. That's interesting about the pregnancy stuff.
Yeah, I kind of thought it would rise out of a few people here.
We teach that it's not that it's safe.
What's that?
We teach that it's safe. And now
well, I tried to highlight that that's what those two sort of position papers did. But there have been some reports that, well, I don't know.
crazy.
Yeah.